Hello, everyone. Good morning, good afternoon, good evening. My name is Katerina Storing, and I co-chair the Collective for Political Determinants of Health. It is my pleasure to welcome you today to the first collective conversation of 2025. For those of you who are new to this type of event, the Collective Conversations is a seminar or a webinar series organized by the Collective for Political Determinants of Health. And the aim is to advance research and debate on how power constellations, institutions, interests, and ideological positions affect health within different political systems and cultures and at different levels of governance. So after many rich and engaging discussions in this forum last semester, we are now ready to kick off a new year. We have 9 seminars lined up. But today's event is co-organized with the United Nations University International Institute for Global Health in Kuala Lumpur in Malaysia, where I'm speaking to you from today. And specifically, it's under the work program on power and accountability, which is led by David McCoy, who is going to be giving some closing remarks later. And in today's event, collective members Ben Hunter and Felix Stein will be discussing findings from their working paper, Private Finance and Financialisation, A Threat to Global Health, which has been published today by UN University Institute of Global Health. We have many people signed up today from all over the world, and we're delighted to have a big audience. And you are encouraged to actively engage with the discussion and to ask questions during the event. And you can do so either by submitting questions through the Q&A function in Zoom or by clicking the raise hand function to ask your questions directly, and you'll be elevated to speaker. To chair our event today, we are joined by Susan Erickson, who is a distinguished professor in the Faculty of Health Sciences at Simon Fraser University in Canada. Welcome, Susan. She is also currently a Mellon Foundation Data Fluencies Fellow at the Digital Democracies Institute. And as a medical anthropologist, she has researched highly complex political economy arrangements and financial arrangements that shape global health, and is so uniquely positioned to lead us through a discussion of the role of private finance and financialization in global health. So over to you, Susan. Thank you very much.
Thanks so much, Katerina. I'm so happy to be here. So welcome to Private Finance and Financialisation, A Threat to Global Health. As chair, I have a few quick notes. One is that our event lasts for 1 hour. Ben and Felix will present an overview of the paper, and then at about 30 minutes past the hour, we'll turn to questions. And 2, the event is being recorded. 3, if you feel comfortable, please do ask questions either through the Q&A function, as Katerina mentioned, or alternatively, click the raise hand button. We'll turn to questions after we hear from Ben and Felix. Ben is a lecturer of international political economy at the University of Glasgow. He works at the intersection of health and development with a particular interest in issues of market formation in and around healthcare. He's conducted research on corporatizations and transformations taking place within private and the healthcare sector, as well as private public partnerships for the private provisioning of healthcare services. Felix Stein is an economic anthropologist working at the University of Amsterdam and the Center for Development and the Environment at the University of Oslo, with a special interest in global health governance, development finance, and public-private partnerships. He leads a 5-year research project on global reparations movements, comparing reparations made over pandemic outbreaks to reparations made over climate change and toxic environments. So welcome to Ben and Felix. One additional note that I'd like to suggest that I think would be a useful distinction to foreground about the briefing paper is for you, Ben and Felix, to note when you are referring to conventional, one can say old-timey notions of health ODA, that is overseas development assistance health funding, versus the new forms of global health financing, like those you feature in the paper, which happen at a different speed, volume, and intensity than ODA, and are being originated with new forms of bank deal-making, fintech, and algorithmic considerations. Value and values are calculated differently. There are 2 different set points for accountability versus investability, and calculative tools are not necessarily geared for how best to intervene for improving health or even favorable foreign policy outcomes, but rather to calculate investor loss probabilities. These are huge differences. Distinctions between old style ODA and new financing would be useful today, I think, as a baseline starting point for the audience. So I am so looking forward to the conversation today. Thank you so much, Ben and Felix, and please begin.
Thanks very much. Hopefully you can see my screen and hear me, but please tell me if not. Thanks so much for the opportunity to kind of have this space to share some of this work. Thanks to Katerini for the introductions and Susan for the introductions. I particularly want to acknowledge right now the fact that this report that we're going to be speaking to, that Felix and I will be speaking to, is the product of several people's work and not just ours. We might be the face of it right now, but actually Anna Carolina Cordia, Anna Maria, Victor Roy, Ben Wood, as well as David McCoy, who'll speak at the very end, have all made hugely important contributions to this report, shaping thinking, writing passages and sections and cases within it, contributing cases. So this is absolutely not just something that me and Felix have been working on, but a product of a much wider effort. That effort itself has its origins in UN University International Institute for Global Health's program of work on power and accountability, which has a sort of section of it, a thread of it, looking at powerful private actors, of which private financial actors is one, and it's private financial actors that are the subject of our report. The reason behind this, and Susan has already kind of spoken to this a bit, the reason behind, why write a report on private finance is, this is something that is really seeping into global health in all sorts of different ways, in different scales, different sites. But we're seeing this kind of growing narrative in particular, often quite unquestioning, uncritical, around private finance as a solution to the problems of global health. And the way we've structured the report, the way we've framed the report, is not a systematic review. It's not an attempt to kind of give even balance to different arguments or anything like that. It is about trying to present a counter narrative in a clear and coherent way. That is the basis for the report. That is the way it is structured when you read it. So it talks about financialization, right? This critical perspective on the growing role of finance in society. And Felix will talk about this shortly. The second section of the report looks at the impacts of private financial actors in global health in various different ways. And Felix and I will talk to that again shortly. And the third section of the report looks at the potential response. So it actually, it tries to come up with what are the alternatives, or highlights what the alternatives, what should the global health community be doing to counter some of these narratives that are increasingly being leveled or put to us. And what I will mention as well is that there's a really valuable glossary at the end of the report for those who have not spent years searching and reading up on finance and who aren't familiar with terms like private equity or hedge fund. It gives a bit of a breakdown, and it's meant as a primer. So the report really is an attempt to try and help to build understanding and build a counter narrative against some of these sort of problem-free framings. So I'm going to hand over to Felix now, and then I will reappear again after he's talked a bit about financialization and some of the impacts.
Thank you very much, Ben. And if you could jump to the next slide, please. Thank you very much. So given that private finance is on the rise in global health, and we all still need to get somewhat financially literate and ask ourselves what financialization might be, this report suggests that one good approach to financialization is simply that it means that our lives are increasingly dominated by the financial sector, including by its actors, its markets, financial practices, by its measurements and its narratives. And this is happening at various scales, and it's changing entire economies as well as firms, states, households, and I would add social groups and people's daily lives. And our financialized world today is different to, say, the neoliberal world and neoliberal policies of the 1970s and 1980s, because while neoliberalism was marked by deregulation, privatization, and the marketization of social protection regimes, our financialized economy today is one where intangible assets such as intellectual property, securities, and derivatives become more important. It's also a world in which individual companies become bigger than ever. So one example for this in the report is that the top 500 asset management companies collectively manage $114 trillion in assets, and that is slightly over 4 times the annual GDP of the United States, and it's over 40 times the funding gap to reach the social development goals by 2030. Lastly, we now live in a world where so many different and increasingly complex financial products circulate that opportunities for rent seeking become greater and greater. And rent seeking just means extracting money from others out of a position of power. And we can see and feel this financialization in our daily lives as logic of credit and debt and investment increasingly shape our health outcomes. So the health of hundreds of millions of people is now shaped by their personal finance decisions, microfinance arrangements, and even crowdfunding efforts, as Nora Kenworthy has shown, as people are frequently reconfigured into being investors in their own health and investors into their own human capital. Meanwhile, in the corporate world, that world is moving towards asset manager capitalism, insofar as shareholders and asset managers gain influence over corporate management. And this changes, for example, how private hospitals are run, leading to greater short-termism in management decisions. And we can also see financialization, of course, at play in health startups, who now heavily rely on promising storytelling, because this can, under the right circumstances, move billions of dollars in their favor. So narratives are getting more and more important in the corporate world. And lastly, governments, particularly of low and lower income countries, are more dependent than ever on private investors to lend money to them. And we have seen some of the health consequences that this can have when things go wrong. And we've seen that in Greece during the 2011 to 2013 financial crisis. But we also see it today in Argentina, which is put through a massive austerity program to make private borrowing by the Argentinian government easier again in the future. Now, governments really grapple with the fact that the kind of financialization we're witnessing is dominated by private finance. So low and lower income countries are witnessing a shift from what was called the Washington Consensus, which told them to liberalize their economies and cut down on the welfare state, to the Wall Street Consensus, which tells them to make themselves legible and attractive for global private finance and to minimize all risks that investors may encounter. Entire countries are thereby being turned into investable assets, but also individual policies such as prison reform, childcare, infectious disease response are turned into objects of investment. And this is done through, amongst other things, the creation of public-private partnerships, the creation of innovative and blended finance instruments, and through discursive changes that present anything and everything as an investment opportunity. And this rise of private finance in health does have strong imperialist aspects to it, because most of the institutions driving this trend are still located in high-income countries. So the faith in private finance that many global health policymakers still have today doesn't fall from the sky, but as Susan and others have shown early on, it's being created by corporate lobbyists, private sector consultants, multilateral development banks, and wealthy philanthropists who are primarily based in the global north. And you can see on one document on the slide by the World Bank that kind of pushes for financialization. And if you could jump to the next slide, please. So to very briefly speak about the impacts and implications of this rise of private finance for global health, one major impact is that private financing tends to be expensive for donor countries, because private investors are usually contractually obliged to seek high returns on their investments. So borrowing from them tends to come at a high cost. And to provide just one example of this, consider the Pandemic Emergency Financing Facility, or PEF, which was launched by the World Bank in 2016. So the official aim of this mechanism was to serve as a financial resource that lower income countries could draw on quickly in case they were affected by pandemic outbreaks. However, rather than just putting public money by donors on the side for this insurance purpose, the World Bank wanted to draw in funds from the private sector. So it got together with reinsurance companies and risk modeling agencies and investment banks to issue 3-year bonds that investors could buy. And those investors who held these bonds received annual interest payments from donor countries, which, if no pandemic broke out, were going to lie between 6.9 and 11.5% a year. But if a pandemic was to break out, they would lose the price of their bonds, and interest payments might also be reduced. Now, this mechanism, the PEF, ended up funding 3 outbreak responses, 2 for Ebola in 2018 and 2019, which you can see on the slide, and 1 for COVID-19. And as part of this last payment, investors lost their money because the insurance was triggered and the bond payments were lost. And if we look at the money spent overall by the PEF, which you can see on the slide, we can see that only 69% went into actual outbreak response, while almost a third of the money that it spent was spent on interest payments, swap expenses, and administration. And so whether there is a pandemic or not, paying close to a third in transaction costs is a very expensive way of financing pandemic response. And with this, I hand over to Ben.
Thanks very much. Okay, so the second area of kind of impact or implication that we identify in the report resulting from this process of private financial actor kind of entry and financialization in global health is relates to shifts really in the kind of the values and the principles of global health that we're seeing taking place. The way in which, and we can be cynical about this, we can be critical about this, but global health generally, I would like to think, is largely governed by ideas around health and equity and justice, humanitarianism, and okay, there are exceptions and we can query it, but those are generally understood to be key principles and values in the community of global health. They're not the values of private finance, right? As Susan has already mentioned, right? They're a different value system at play, and what the financialization of global health entails is reorienting global health and the institutions of global health towards the interests and the language and the ideas and the instruments of private finance, which means catering to the needs of private finance. It means incurring the kinds of costs that Felix has talked about, and that being seen as something that is natural because this is what private finance needs. This is the kind of, if private finance is going to be a legitimate partner in global health, then we need to cater to its interests. So we're seeing this move towards actually not so much being driven by health needs and justice needs, but the needs of the investors whose money we want to draw on in order to pursue global health ambitions. This move towards a particular form of input and catering to the needs and the language and the idea of that input. We're seeing it within global health institutions. We're seeing it within the kind of domestic settings as well. Felix has mentioned, when talking about financialization, the sort of the shift in the corporate model, the shift in the business model in different sectors that has played out, and which is playing out in healthcare as well. So we're seeing healthcare companies which are receiving large amounts of private investment being remodeled in ways that will boost surplus revenue and boost shareholder value, because ultimately that is the driving force behind the interests of the investors. So with healthcare provision, for example, the expansion of corporate forms of healthcare and corporations being an important form of important vehicle, a legal entity that can receive investment of the size and scale that investors want to make. We're seeing that it is expanding, but also adopting practices which are incredibly exploitative and run counter to ideals and ideas of health and justice. So the growing evidence around unnecessary testing and treatment in certain settings, exploitative billing practices, the detention of people for non-payment of bills. There was just a media report some of you will have seen in Bloomberg last week, which talked about that results from an investigation into looking at practices of hospitals around and showing things around detention and exploitative billings, but also pushing downward pressure on costs of healthcare providers, pushing down employment conditions, particularly for junior and less established professions or more precarious forms of employment, in order to try and reduce costs and maximize revenue in order to enable greater extraction of resources by investors. This is something we've seen in pharmaceutical sector for a while. We've seen this shift away from, particularly amongst larger pharmaceutical companies, away from certain forms of research and development, and instead a preference to acquire companies that are doing the research development, often companies that have received public subsidy in order to develop new pharmaceuticals, being acquired by multinationals, because that's a more or lower risk approach to take when it comes to development of new products and new pharmaceuticals and health technology products, and which of course then feeds into this kind of system of intellectual property and enables incredibly high pricing of products and the neglect of issues which are not, and the neglected regions and areas which are not seen as profitable. To give a sense of, and it's quite a narrow set of examples here, but I've put up on the screen some data that give a sense of just how large the extraction of some of resources, of wealth from healthcare systems is. So these are based on the work of Ben Wood, for example, and Victor Roy and other people who've been trying to kind of number crunch a bit around this. But following or during the COVID pandemic, because of the profits that the leading vaccine manufacturers accrued, they were able to do huge shareholder reward schemes involving dividends and buybacks, totaling $13 billion. Right, so that is money that was leaving the healthcare system to go to their investors, their shareholders. The largest health insurers in the US in 2023 alone allocated $26 billion in share buybacks. The 14 publicly listed pharmaceuticals in the US spent $750 billion on share buybacks and dividends during the decade up to 2021. So just an indication, and from a particular context, because that's where people have done the research, that's where the data has generally been more available. But a sense of just the size, the scale of resources that can and are being extracted from healthcare systems, and facilitated by this kind of remodeling and repurposing of the values of global health and its institutions that we talk about in the report. The third area of impact and implication that we talk about in the report relates to loss of accountability and issues around regulation. So we're seeing, with the shift towards private finance and public organizations, multilateral organizations looking to facilitate that, we're seeing a weakening of democratic governance and issues of regulatory capture. And again, other people have written about this, in particular Susan Erickson, about the kind of secrets of private finance, that this is an area where disclosures are very limited. Not much information is revealed. It's hard to get hold of information on financial transactions, on the activities of private financial actors. What is available is difficult to interpret because of the complex language, the complex data involved. It's fragmented. People who've done research on this will tell you it's hard to piece together and actually build a clear picture of money changing hands and who benefits and who doesn't, who's paying ultimately, who foots the bill. So this is an area where it's difficult to monitor and keep track of the kinds of changes taking place, the kinds of flows taking place. And public institutions are proving either unable to do this, to monitor and to hold private investors to account, to regulate, or unwilling to do so. And just to give an indicative example here, that one of the cases we refer to in the report, development finance institutions, which are these private investment arms of the World Bank and of high-income governments, which look to support and crowd in private finance into various sectors, including health. have responded to criticisms by saying that they have limited influence over how the companies they invest in operate, that they have limited opportunities to disclose certain information because of commercial sensitivities. That, even when you've got the case of UK British International Investment, which actually does have a framework for looking at the impacts of its investments and the co-investments it makes with private investors, it has apparently applied that framework to examine the healthcare system impacts in 3 cases, but refuses to release 2 of those for public consumption, raising questions as to what they might contain. But again, the grounds being commercial sensitivity. So the kinds of institutions who are using public funds to subsidize private finance are not able or not willing to actually provide information and to monitor and to examine and evaluate the kinds of impacts that this is having. So to come on to the sort of final section of the talk and the final section of the report is where we discuss potential responses, and we divide this into 3 kind of areas. The first being to try to challenge some of the common fallacies, the false narratives, the problem-free narrative being presented that private finance is the solution to the problems of global health. This kind of short-termist simplification, and to call it out for what it is, and to call out language like this being a win-win approach, to call out language like investment. Investment implies at least a net benefit in the direction of the recipient of investment. But, like Felix has pointed to, like other examples point to, there are enormous outflows that follow. Investment is not a one-way process, it is a 2-way street. And yet you wouldn't know that from the way people talk about it. Risk management, or de-risking, this euphemism for public subsidy. So, the need for a global health community to get to grips with some of the language that is being used to discuss private finance and to challenge some of the narratives that we're seeing emerge and being presented. The second area where we highlight the second area of response relates to policy amongst key public and multilateral organizations, that there needs to be better monitoring of the impacts of private investment in different sectors affecting global health. There needs to be evaluations where investments are being made in the name of development in ways that are not being done. That there needs to be, some of these non-health focused organizations like the development finance organizations need to incorporate values and issues of health into their decision making, need to take into account impoverishment in their decision making, rather than saying, well, we're interested in broad economic growth and creating jobs, and therefore it doesn't matter what the impacts are on health and access to healthcare as a result of our investments in corporate healthcare provision, for example. And there is an open statement that is open at the moment for signatures, which calls for DFIs to stop investing in private, in corporate healthcare provision because of the kinds of problems it creates, and the process of financialization that they're intensifying by attempting to draw in more private finance into this sector and support further growth. And we actually do point to areas where there is potential for greater regulation with regards to private finance and global health, looking, for example, at the potential for limiting the entry of certain investors, certain types of investors like private equity, looking at the opportunities for preventing acquisitions in certain sectors where it might lead to monopolies emerging, looking at caps on profiting. And it's interesting to see that the US, for example, in the US, various state level legislators as well as federal level committees are looking into the potential for tighter regulation of private equity involvement in the US context. And the final bit before I finish is around the alternatives, right? That often people say, well, the classic refrain of Margaret Thatcher and neoliberalism, that there is no alternative, but there are alternatives. Okay, and it's important to kind of highlight the fact that there are alternatives that will reduce reliance on private finance, that involve greater potential for using public financial infrastructure, which exists but which is generally under-resourced. That means ministries. It also means state-owned apparatus like development finance institutions, like national development banks, which could be given a stronger social mandate in order to refine and focus their investments on actually making improvements in health and development and preventing impoverishment. And there's also the wider processes going on around debt justice, around tax justice campaigns, which global health needs to be part of in terms of feeding into that, drawing from those campaigns, advocating for debt cancellation, advocating for global tax justice, the global tax treaty and tax body, as ways of actually providing a more progressive form of financing to address the kinds of issues that are emerging, but for which private finance is very clearly not the answer. So I'm going to stop speaking there and hand back to Susan. When there's the link for the...
Ben and Felix, thank you so much for such a great overview of a truly worthwhile report. I encourage everyone to read it.